If you watch this channel, you know I'm all about using data to track my health. Take everything I've learned along my journey and put it to work for you with my GLP-1 Journal. With 16 rounds of 4 weeks each, this interactive PDF digital download spans a period of almost 15 months, long enough to potentially lose 100 pounds or more. Follow my strategies in real time, with space to input your goals and how you reward yourself, a self-assessment to plan ahead for those tough days, areas to enter and track your measurements, monthly, weekly, and daily tracking checklists, and more, all for less than the cost of 1 month of groceries. Use code BLACKFRIDAY at 100poundsdown.co for 30% off. Hurry! The sale ends at 11:59 p.m. on Cyber Monday. Welcome back to 100 Pounds Down, where we preach the gospel of GLP-1 and the word is good. I'm Kristen DiBiase, and after a lifetime of struggling with obesity, I lost over 41% of my body weight on tirzepatide, also known as Mounjaro and Zepbound, and I'm never going back. If you've been considering anti-obesity medications like these, Ozempic or Wegovy, you're already in the middle of your journey, or you're getting close to that maintenance phase and wondering, what comes next? Bring it in. Now, let's talk about our final area of focus, which is the high-level leadership appointments that Trump has made. First off, Trump has appointed Russell Vought, who is one of the primary architects of Project 2025, to be the head of the Office of Management and Budget. This job is basically like the head accountant for the entire country. It is the person who is very, very closely in charge of how much money is spent where. It is an organization that will often give estimates. It is an office that will talk about ways to find efficiencies in order to get things done under various priorities that each administration has in place. This is a very important role that most people don't really pay a ton of attention to, but which is critical, especially because we already know about the priorities that I explained. Within Project 2025, there are many areas where the game plan for what to do with departments that they don't want is just to drastically defund them by cutting down on their budgets. When we talk about, just completely abolishing, for example, the Department of Education, which we're not going to really get into. There's debates on whether or not a president can even just get rid of an entire department. And so if the president can't do that, then the next best thing is just to drastically defund. And so that is the position that Russell Vought has been put in charge of doing. And again, this goes right along with the recommendations that DOJ will be putting into place. It remains to be seen whether or not folks will agree with some of these ideas. But anything that does not have to go through Congress and that can be done by executive action or simply by the authority that is placed in the person who is the head of that agency, those things can be done if there are not rules or guidelines that are restricting them. And again, even if there are rules or guidelines that are restricting, nothing stops people from breaking rules. Just like I tell people all the time, nothing stops you from being sued. It's what happens after that is critical. You can't stop somebody from suing you. You can't prevent somebody from breaking a rule. It's what happens after the rule is broken that is important. And if what happens after the rule is broken is that the folks who are supposed to be the referees on whether you broke the rule or not, if they decide, you didn't break the rule, and they explain in some convoluted way why the rule wasn't broken. Well, the rule wasn't broken. And that's the thing that can absolutely happen. Now, we'll get into the appointments that are much closer to what we are specifically focusing on here with GLP-1s. So starting off, Robert F. Kennedy Jr. Was appointed by Trump, or is being floated as the appointee to be the head of Health and Human Services. Very early on, Trump had indicated that he planned for RFK to have significant input here. But there was really debate on whether or not he would actually make the appointment of RFK to that actual role as the head of HHS. But he did make the appointment. So what does this mean? Well, first off, check the description, check the comments. I have a link to the org chart for Health and Human Services. It is a massive department. It has tons of offices within it. And so this is a very, very huge job. And as I mentioned earlier, typically the people that are heads of various areas are going to, in normal times, be people that have some kind of skill set or background that lends itself toward being a place where they can function in the role that they are serving as the head of an organization, aside from simply having opinions on a matter. RFK is not a doctor. RFK is not a scientist. And yet RFK is being touted as the person who will lead the Health and Human Services Department, which is, of all of the departments, the most health and science oriented of all of them. And all of those agencies that fall underneath that department. Only days after the election, RFK had announced that the Trump administration would be immediately firing and replacing 600 officials who work for the National Institutes of Health, which is one of the agencies that is under Health and Human Services. Again, going back to what we talked about before, getting rid of those people right off the bat and then replacing them with folks who are loyal to Trump and the Trump administration. Again, regardless of the fact that most of the folks who would be being terminated are career civil servants who have specialized skill sets that are important to the work of all of those agencies. Because there is this uncertainty that is floating around about what direction their agencies might go, you are seeing loads of older scientists at the NIH, at the FDA, at the CDC, the Centers for Disease Control and Prevention. A lot of those people are thinking about hanging it up and going for retirement now. And so then that is another issue. It's not just if they are terminated, there is the specter of possibly being terminated that drives some people with extensive experience and a lot of times a good amount of institutional memory to leave these organizations. Again, just making way for loyalists who are not as skilled or trained to come in and take those positions. One of the things that RFK will likely probably do as the head of HHS will be to increase a focus on fighting chronic disease, which honestly is great. There are some opinions that RFK has that I absolutely agree with. He is a vocal opponent of ultra processed foods and the impact that they have on obesity and other chronic diseases. There's definitely something to that, right? And so he does have this idea of, just having healthy, good, better food. Um, Unfortunately, given that we are looking at him being the person who is over HHS, there's not necessarily going to be as direct an impact on food issues as if maybe he was Secretary of Agriculture, for example. But there could be many areas where he could have an impact um, on policy within those agencies that fall under HHS. His Make America Healthy Again team has long called for the government to cut ties with industry, so big food, get rid of sugar, get rid of processed foods, get rid of toxic substances that are in the American diet. Now, there's a bit of debate on certain substances and whether or not those are toxic or not. But the over processed food, the extensive extra sugar, I can get on board with that. Having said that, though, part of his beliefs that go along with that is that he is very kind of a staunch, like, anti GLP-1 person. He, unfortunately, is one of those people that subscribes to that school of thought that I argue so much against here on my channel. He is one of those people that thinks if you just eat good food and you exercise, that's all it's going to take, and that's it. All you need to do is exercise and eat better, and if we get processed food out of our diets, then obesity would just absolutely go away. So really just looking at diet and exercise, which, as you all know, if you are a watcher of this channel, we know it's not just those two things. So he could really be, at least attitudinally, a stumbling block for GLP-1, but not all is lost. And we will get to that a little bit later here. Now, one thing that he may try to do is end drug advertising on TV, which admittedly is kind of weird anyway, and is a very odd, almost completely American thing. Honestly, aside from us, like, we and New Zealand are the only countries in the entire world that have pharma advertising on television. We are extremely, like, weird in that way, where other countries, they do not allow it to happen. So if you could imagine for one moment having no pharma ads, and big pharma, they spend a lot of money on television advertising. Now, one thing that he has talked about targeting that I don't really like is he might also target company user fees that subsidize drug approval reviews. So the Prescription Drug User Fee Act is an act that was put in place. It was passed by Congress, and it charges pharmaceutical companies millions of dollars to cover the cost of what the FDA does to review all their applications to decide whether to approve new drugs. This is a huge portion of the FDA's budget. It is around $3 billion, billion with a B. Honestly, it remains to be seen whether or not he would be successful in getting movement on this, because Congress are the people who set the prices for what those fees are. But if he was somehow able to get movement on that, okay, so we've just cut $3 billion out of the FDA's budget. So either that cost needs to be made up someplace else in the federal budget, which means they're going to be making cuts someplace, or there's going to be, again, a drastic slowdown at the pace at which new medications are going through that review and approval process to get new drugs to market. So if he's able to do that, that's a lose for people who are on GLP-1 medications, because it's going to be a longer period of time to get those new drugs that are in the pipeline out through the other end and approved and available for the general public to be prescribed. Next, let's actually talk about the FDA. So Trump has appointed Marty Makary as the head of the FDA, which is honestly going to be an interesting interplay when you've got him heading up the FDA, but he's doing that under RFK Jr.'s leadership at HHS. So let's talk a little bit about Marty Makary and his background. So first, he's a doctor at Johns Hopkins. He's most famous for being the doctor that came up with the concept of pre-operation medical checklists. So he's the guy that really started that process, and that has revolutionized safety in hospitals. It has made surgery and recovery safer for people all over the United States. He's also a proponent of hospital price transparency. So he's not a bad person to have as the head of the FDA. And this is where things actually start to look up. There are some possible bright spots here for folks who are on GLP medications. So first off, he's the chief medical officer of Sesame. Now, for those of you who don't know what Sesame is a telehealth company that connects people with doctors who prescribe Plan C versions of GLP-1 medications. So, given that he currently is the chief medical officer for a place that its bread and butter is made by offering people Plan C options, I think there's a pretty good chance that if he's the person who's the head of the FDA, Novo Nordisk is maybe not going to be so successful in their quest to get semaglutide or other GLP-1 medications added to that DDC list, that demonstratively difficult to compound list that would essentially take the Plan C option completely off the board for people. So that is an interesting little twist here. When you are looking at that idea, kind of doesn't matter. I think that RFK Jr. is kind of anti-GLP-1. He's already said he's not going to take drugs away from people. He believes in, people having free choice to pick medications or not, but he himself is not a fan of GLP-1 medication. For someone who is not a fan of GLP-1s, I think if he is going to be confirmed, it's probably best that he is where he is, which is actually at the head of HHS, because in many ways, he doesn't really have as much power as he could have at lower levels in roles over specific agencies. So that's kind of ironic, but again, it makes a lot of sense when you think about the way that these roles are put in place. They're federal appointments. Somebody that's really high up, again, most of the time they've got the chops in the background to be doing the job that they're doing. And so they really can have quite an impact in leading whatever direction those agencies underneath them want to go, especially when they have some executive power to make decisions. But if you're somebody that actually doesn't really have the skill set and the knowledge to understand those areas, you don't have enough information to even know what you can do. It's really kind of easy when the person in charge of something doesn't know what they're doing to go around them and to kind of do things the way they've always been done, or do things in a way that you kind of slow walk policies that are not good, things like that. Honestly, for a lot of the last Trump administration, that was what ended up happening within a lot of the executive branch agencies. And that is why, as part of Project 2025, they were looking, and at the end of Trump's first term, toward the end there, he was looking at this Schedule F thing. Because when there's people that know what they're doing and have skills and are career civil servants that know what they should be doing and know how to get the work done, a lot of times they're not going with whatever you want them to do, be that because it's illegal, it doesn't make any sense, it doesn't follow accepted science, all kinds of reasons why not. And that's again why loyalists are what Trump wants in place, because they will do what he says to do, regardless of whether or not the results could be drastic or very catastrophic. The other bright spot to having Marty Makary in this role at FDA is that more than likely he's going to make things possibly easier for folks who are in big pharma, because he's got connections with folks who have been there. That is one of the things that RFK Jr. has not been a fan of. And honestly, when you look at Project 2025, there are several sections in that document that talk about something that honestly, I don't think I actually disagree with. It talks about how big pharma and the government, that the organizations that are in charge of regulating and doing all of the things that guide what big pharma does, that the pipeline from big pharma to oversight of big pharma in the federal government and vice versa is far too speedy and porous and incestuous. There is a problem if the same people who just months before were running a government agency that oversees a certain group of pharmaceutical companies are now suddenly the heads of those pharmaceutical companies, or someone who used to be the head of a pharmaceutical company is now suddenly a major high-level administrator within one of these government organizations that oversees big pharma, like the CDC or FDA or any of those other agencies that fall underneath Health and Human Services. So there are some places in the document in Project 2025 where, generally speaking, there are some things that sound a bit more common sense. I do think that there need to be some safeguards. Now, the thing that is the argument on the other side of that is, and I think that in many ways it is a valid argument, and there should be a better way of mediating between the two sides to this argument. It's again the idea of people who work in the pharmaceutical industry are the ones that have the experience and skill to understand what they are reading and what they are looking at when pharmaceutical companies come before them and make claims about product efficacy and show the documentation of what has happened when they have completed clinical trials, things like that. It takes people who have experience in those industries to understand and to be able to have the skill to evaluate things that come in from those industries. And so I see both sides of that argument. And I think that the suggestion of what really works in that situation is to have some kind of guardrails around things. You shouldn't be able to immediately leave a pharma company and get put in charge of an organization that is currently reviewing said pharma company. Maybe there are recusal procedures and processes that can be put in place, or that can be revamped to make it more enforceable in a way that makes sense, instead of just letting that relationship be extremely porous in that way, because it does lead to the appearance of conflict of interest. And that as much money as is coming in from big pharma, people are thinking that, oh, it has to be, something where they're just automatically approving things. And I don't think that that's necessarily the case. I think FDA has been pretty good about regulating and being very careful with what they allow in some situations. But yeah, it's definitely something to think about. The last appointment that Trump made that I want to talk about today is that of Dr. Mehmet Oz as the head of the Centers for Medicare and Medicaid Services, or CMS. So, as background, Dr. Oz, as many people are aware, started out as a heart surgeon, and then he got popular from appearing frequently on Oprah's show. He then eventually, in 2009, got a spinoff to his own show that ran for 13 years. At various points in time, however, on that show, he has made dubious claims about weight loss supplements and other treatments that are not evaluated by the FDA. And he's also been less than forthcoming about his connections to companies that were sponsors of his show, or companies that he himself had some kind of an ownership or partnership stake in. Multiple lawsuits about those issues were settled out of court, and he's also been questioned by members of Congress and at points denounced by his own medical colleagues. So, what is CMS responsible for? I mean, obviously, we're going to see that it's responsible for Medicare and Medicaid, but they're also responsible for the Children's Health Insurance Program, or CHIP, and the Affordable Care Act, the ACA, also known by many people as Obamacare. So together, those programs that I just listed out cover more than 160 million people in the United States. CMS also sets the Medicare payment rates for hospitals, doctors, labs, and other service providers. And this is important because Medicare payment rates are usually the starting point for private insurance companies to set their rates as well. So, what could possibly happen with this particular appointment? Well, first off, Dr. Oz is actually a big fan of GLP-1 medications for obesity. He's also really excited about their potential for treatment in areas that are outside obesity, in those expanded areas of health, like Alzheimer's research, addictions, things like that. However, again, as we have already discussed, RFK Jr. is very vocally not a fan of GLP-1 medication. So it could be, again, that if RFK does have the ability to kind of articulate that vision, that there could be some pushback when it comes to whether or not Medicare could be covered. Again, just mentioning, RFK said nothing about, rescinding approvals for various drugs or anything like that. Now, currently, when it comes to our big two, Eli Lilly and Novo Nordisk, right now, Mounjaro and Ozempic are both covered by Medicare, but very specifically only for diabetes. And then Wegovy is actually approved for heart issues and for obesity. So that is where things currently stand. Lilly's medication currently is not covered by Medicare for those things. Now, Medicaid is different in that that is typically decided at the state level as to whether or not the various insurers for the states will cover that particular type of medication or anti-obesity medications on their formulary for Medicaid within those different states. So it really depends state by state whether or not some folks are covering it or not. Now, another thing that I've noticed about Dr. Oz is that he is a huge fan of Medicare Advantage plans. And this is where I immediately say this is way too much to go into like any kind of depth at all in terms of talking about Medicare versus Medicare Advantage. It is not an area that I am well versed in at all. And so the main thing that I want to highlight for you in terms of the differences between the two is that Medicare is government sponsored health insurance for seniors that are 65 years of age or older, and for some people that are below the age of 65 if they have certain disability, if they're disabled. So Medicare is much more rigid in terms of what is allowed to be covered and what is not by law. Medicare Advantage is private health insurance. So it is privatized, but basically you can go on a Medicare Advantage plan and then the government will help pay rebates to the Medicare Advantage insurance plan to subsidize the cost of that plan. Now, the thing that makes Medicare Advantage different from Medicare is that typically the premiums are less, and it also involves a lot of other benefits and perks that are available that just regular Medicare is legally like not allowed to include in their plan, like dental, hearing, optical, those kind of things. And even, other perks that they just toss in a lot of times, like a gym membership or things like that. Now, when we get back to this idea of RFK again, because we're now talking about Medicare and Medicaid, RFK, again, with his, make people healthy again thing, and his good food thing and his exercise thing, he has said he would like those options to be covered in the same way as medications might be covered. So if he had some influence there, then perhaps things like gym memberships and things like that might end up being covered if Congress were to change the laws to allow other things besides just health care could be covered under the regular version of Medicare. So right now, slightly more than half of seniors that are eligible for Medicare, I think it's around 54% now, are actually on Medicare Advantage plans. And so it begs the question, right? Like, why would one person prefer to be on regular Medicare instead of Medicare Advantage? And the answer to that is honestly, depending on who is running the Medicare Advantage plan. A lot of times, the reasons that those plans are cheaper is because um, often they are a lot more restrictive on where you are allowed to go, like who's in network and who's not in network, things like that. There's also allegations that people have made just in general that a lot of the time Medicare Advantage plans will cherry pick and only kind of sign people up who are relatively healthy for being that age. So they will just kind of preemptively not accept certain people who look like they are going to be a higher insurance risk. And that is another thing that ends up happening. Or a lot of times there's been accusations that many of the Medicare Advantage plans will require a lot of prior authorizations, which is where you have to ask for permission to go to a certain doctor or to have a certain procedure done beforehand. So either through getting a prior authorization for a procedure or a type of a medication, or getting a referral from a primary care doctor to be able to even go see another doctor. And those are restrictions that largely are not there with regular Medicare. Regular Medicare, you can go to any doctor that accepts Medicare. There are lots of things you cannot use regular Medicare for, but that's why there are then additional parts that kind of go together with Medicare. Medicare Part D is the prescription drug coverage for Medicare. And you can have Medicare Part D even if you have a Medicare Advantage plan. There's a lot of kind of overlap in certain different things and in how that works. So, Dr. Oz is a big fan of Medicare Advantage plans. He often would hawk them. He currently still does, I believe, like as part of his website. But he would often be hawking those like when he had his show in the past. There is the risk that he would want to privatize Medicare entirely. So that by default, anybody who gets on Medicare is gonna by default go onto a Medicare Advantage plan instead of being on regular Medicare and maybe having gap insurance in case something were to happen where there's a catastrophic event where it's just an extremely expensive amount of money that is being spent. Now, one of the things that is important to talk about here as we're talking about this idea of Medicare, and again, leading it back to what is the impact for us and folks like us who are taking GLP-1 medications. We talked earlier about which medications are currently covered on Medicare. With Medicare Advantage plans, it is, again, it's going to really depend on the specific insurer as to whether or not your medications, your GLP-1s are covered on their plans. A lot of those, it's not going to be covered on them. And that's because they are so expensive. Even though there is the subsidy that comes into play from the federal government. So the reason that we talk about this here is because of one other area when we talk about, that high level policy initiative. One other thing that I did not mention at the top when we talk about some of the high level policy is just in general, anything that was put in place by the Trump administration the last time that was rescinded by the Biden administration. In the meantime, there's going to be an attempt to revive those rules, those executive orders, those things again when these people come back. So, one of the things that was put in place that was so important and critical for people and a huge change was the Inflation Reduction Act. And that was passed during the Biden administration. The Inflation Reduction Act does a lot of different things, but one of the things that it does that a lot of people know about is it gives the government the ability to negotiate with pharmaceutical companies about the price of prescription drugs. Previously, there's a rule in place that said that literally, like, they were not allowed to do that, which is honestly insane because every other country basically is able to negotiate with the pharmaceutical companies about how much they're going to charge for the drugs that they are selling in their countries. And that's why it's so less expensive in other countries compared to here. Passing the Inflation Reduction Act was what led anybody who is on Medicare to have a cap of $2,000 out of pocket on their medical costs. And it was able to get folks who are on Medicare to only have to pay $35 a month for insulin. So insulin was one of the very first drugs that they negotiated the price cap on. And under the rollout of the Inflation Reduction Act, over the next couple of years, there are more drugs that come onto the negotiating table in order to be discussed in terms of how much they can negotiate for. That is something that I feel that a GOP dominated Congress will definitely want to be trying to repeal or get rid of if they are able, if it is possible. I'm sure that just like when the ACA was passed, I mean, they tried so many different times to get rid of the ACA. Unfortunately, the ACA was really popular because, of course, people want to be able to not get kicked off of insurance or not be denied even having insurance in the first place because of pre-existing conditions. Of course, people wanted the ability when they are young people in the world that we live in the United States right now, that they could stay on their parents' insurance until they were 26 years old. Well, you know, a lot of them are still in school. Of course, people wanted those kinds of things. So it was really popular, and that's why it was so hard to get rid of. I feel that the IRA will be something that is like that. And so maybe that will make it more difficult to undo because I know there's a lot of seniors who are on fixed incomes and who are really happy that they only have to pay $35 for insulin. Now, where does that leave us when we are folks who are GLP-1 users? Well, if the Inflation Reduction Act is repealed, that essentially will put us back in a place where we were before, which is the government is not allowed to try to negotiate the price of medications. And while there's not that many now, there were going to be a few more as the time rollout of that act continues. But if we go back to a point where we were before this act was passed, and you couldn't negotiate the cost of any drugs, then again, we're putting the entire federal government and people who depend on it for their insurance at the mercy of pharmaceutical companies who are deciding how much money they want us to spend on the medications that people are using. And so the long tail of that decision would be it would continue, in my opinion, to be a thing where they will never just out and out approve GLP-1 medications for obesity across the board in a more widespread way until the point that generics come on the scene, because it's just too expensive right now. With the number of people who suffer from obesity and obesity related conditions right now, if every single one of those people who are eligible for Medicare right now or for Medicaid, if every single person who was eligible for those two programs who also has obesity or obesity related chronic illness were to suddenly be covered because of just how much it costs for GLP-1 medications. And so that's really the impact of what's happening here. If Dr. Oz is successful in his zeal for Medicare Advantage plans, in the sense that they then become the default for folks who are put on Medicare, instead of them having the choice to choose Advantage plans or to choose regular Medicare, which we do know does cover at least Mounjaro and Ozempic, and for some people, Wegovy, at a substantial discount, since they would be having it subsidized under the current plan. And there could be a chance that they could eventually, as the federal government, negotiate the cost of those drugs down, because those drugs, again, start with that Medicare cost for private insurers. That would only lead to the cost and the amount that people's insurance would be willing to cover to come down. And eventually, the pharmaceutical companies would hopefully come down on the cost of that medication. But if everybody has to be on an Advantage plan and the IRA is repealed and we don't get the opportunity for the government to negotiate the cost of medications, these medications will continue to be expensive for a while until they come off of patent and generics are available, which means that people who go on Medicare Advantage plans, because it is cheaper for them on the front end with their, their premiums that they are paying, those people who end up realizing just what all the plan does not cover, and in many cases, the GLP-1 medication being one of those things that is not covered, that's the danger that we face here.
Hey friends, it's Editing Kristen yet again. I already told you all how many times I had to just keep stopping and rewriting and re-recording because information kept changing over and over again. Well, literally, as I finish completing the editing for this video, I open my email and I see a news alert that tells me that the Biden administration is trying to get Medicare to cover obesity medications, GLP-1 medications. So listen to what I said before this, but look for something different to be in a new video I'll be dropping soon.
So that's the tea on what could be in store when Trump takes office in 2025. If you think weight loss injections might be right for you, talk to a medical professional, preferably an endocrinologist or an obesity medicine specialist, because they are the ones who know these meds the best. As always, I'm not a doctor and I'm not sponsored by any pharmaceutical companies. I'm just one woman who's sharing my own experiences and giving my opinions. And finally, if you find my channel helpful, absolutely, please like, subscribe, notifications, and I'll see you on the other side.